Strategy Committee, and also I'd like to welcome Lord Patel, who is Chair of the House of Lords Science and Technology Committee. Thank you. Perhaps I can start before turning to colleagues with some questions, perhaps starting with Sir Patrick. Sir Patrick, without the proposed new measures that were announced on Saturday to be debated tomorrow, how many deaths a day from COVID do you expect the peak to be this winter?
Well, I think it's very difficult to put numbers on an exact peak and when that occurs. What we can see, though, is that the R remains above 1 everywhere. The epidemic continues to grow. And if you take the 6-week forward projection, which is the part of the modelling where you're going to get greatest reliability, because obviously in any model which relies on data, theory and assumptions, the further you go out, the more unlikely it is that you get the number exactly right. But as you come nearer, you get more accuracy. And those 6-week projections, which the SPI and modelling groups have been looking at for the past number of weeks, have turned out to be pretty good in terms of tracking what happens. They look as though over that period you would expect the number of deaths, perhaps if nothing changed, and that's important because things clearly are about to change, but if nothing changed, you'd expect the number of hospitalisations to breach the first wave number probably towards the end of November, and you'd expect the number of deaths to potentially equal the first wave numbers somewhere in mid-December is what they look like. So that's the sort of range that you think of in terms of the trajectory if nothing changed from where it was now.
From where it was now, so before these measures had been introduced?
Yes.
Yeah. And can you just explain how this relates to the chart that you presented that had some different curves from different research groups that there's been quite a lot of public interest in since?
Yes, so when that was presented on Saturday, what I said was those were scenarios that were put together to try to look at what a new reasonable worst case scenario might look like, and they're from a couple of weeks ago, and they are longer term modelling, so they come with all the caveats in terms of the accuracy. And what you can see is obviously there are different groups that have done those scenarios, and they've made assumptions. The assumptions they were given at that point were that the R would be between 1.3 and 1.5, that it might go up by 10% over the winter, and they modelled on that basis, and you can see the different groups came up with different peaks as a result of that. And that would be to inform a reasonable worst case scenario. And another example might be if you go back to June, the Academy of Medical Sciences did a reasonable worst case scenario for the winter, which came up with higher numbers at that point. So that curve was to then lead into the 6-week projection, which are the ones that I think carry more validity in terms of the numbers. But again, they're still a model, so you just project forward for that period, and you see that quite quickly we reach the similar sorts of numbers to first wave on those. And that's the 6-week ones are integrated across all of the models.
And so is there a consensus view in SAGE through the modelling group as to when the peak will be, assuming these new measures don't come in, and what level it will be?
So the consensus statements are the 6 weeks medium-term projections. They are consensus from all of the modelling groups taken through SPI-M, projected forward over that 6-week period. The other graph is something that would come into a reasonable worst-case scenario consensus if that's what the Civil Contingency Secretariat want, and they would commission that. So at the moment, that is not a consensus. That is independent groups having modelled against a series of assumptions.
So SAGE hasn't come to a consensus view as to what the modelling predictions would be?
For the 6 weeks, yes. Beyond that, no.
I see. And just turning to the NHS capacity, again, without the proposed measures being taken, when do you expect the acute bed capacity of the NHS to be used up through COVID patients?
Well, I may bring Chris in on this as well. Clearly, what the SPIAM group can do is model forward the epidemic. Those are then provided to the NHS, and clearly the NHS owns capacity modelling because they know what the capacity is, and we don't have the insights into the exact bed capacity. But the sorts of numbers that, if you look at where the 6 weeks take you, suggests that the first wave peak equivalent is somewhere at a national level, somewhere towards the end of November, with then greater pressure thereafter, but that won't be even across the UK. And so some hospitals are clearly under pressure now, others will be under hospital later. So again, that's an average, not expected everybody to follow that curve. But Chris, you may want to say something about that.
Well, I think it's also important that, I mean, a lot of, certainly the advice I've given is not based on significant forward modelling, it's actually based on what has happened and what is observable. So if you look at the number of inpatients, and I'm just using here management information service data, but I think it's broadly accurate for England. In the 7th of September, 536 cases. By the time you get to the beginning of October, about a bit over 2,500. As of today, it's actually breached 10,000 people are in hospital. So I think you don't need too much modelling to actually tell you you're on an exponential upward curve of beds, and this is completely repeated when it comes to the ONS data, looking at the, again, this is backward-looking data, looking at incidence over time, which has followed a very clear upward trend. And what we know with all epidemics is what you get is it's a doubling. Epidemics are either doubling or halving. This is currently doubling, and it is doubling at slightly different rates around the country, and bits of the country are starting at different stages. Now, I think there are probably two things to say about your question on beds. The first is that the starting point in terms of how full they are now is currently very variable. So there are some hospitals, particularly in the north of England, which have actually now reached levels of COVID occupancy higher than they had in the first wave. And our worry there is, although in those areas it looks as if the increase in rates, the R in the community, is flattening, it has not fallen below 1 as far as we can see. It is still going up. And if they started carrying on going up from this very high base, they would get into serious trouble on inpatients very quickly. There are other bits of the country, for example in the southwest, where the rate of increase is actually faster than in the north now, and the bed capacity is lower. So although they look further away at the moment, they could hit difficulties relatively quickly. The other thing, just to be, to make an obvious point, I hope, to this committee, but I just think it's worth it for those watching, is that there are several different sort of, in a sense, barriers you go through in terms of hitting capacity in the NHS. And the first thing that we would start to have to do, and are already having to do in some areas, is actually cancelling non-urgent elective care. Then you go on to starting to impinge on urgent but non-emergency care. Then you get into the acute care being constrained, and finally into all the intensive care capacity being used up. Now that happens in sequence, but we're already seeing in parts of the country having to cancel non-urgent emergency care. And if this continues, people worry rightly about all the non-COVID care being affected. And I think the thing which the argument on this has got slightly the wrong way round. The way you prevent those services being impinged on and potentially being slowed right down, or even in some cases cancelled, is to keep the COVID rates down.
Indeed.
If you don't, then that is going to erode the NHS's capacity to do not just the COVID care, but actually the non-COVID care as well.
And specifically, one of the slides that Sir Patrick presented on Saturday, looking at projected bed usage, was that the spring peak would be exceeded without these new measures on the 20th of November, thereabouts, with extra beds that would be a few days later, and even with the extra capacity that comes from cancelling operations, that would be early in December. Does that reflect your joint view of what would happen to hospital capacity usage without these measures?
I think there is some evidence of some slowing in particularly the northeast, possibly the northwest, that might push that out in time. But until you actually start to see rates falling, it's a matter of timing, which we exactly get into for these various stages. And they say they don't happen all at once and all at the same rate at the same part everywhere in the country. But the trouble about things that start doubling is you move from very small numbers to very large numbers surprisingly quickly.
So, as is clearly the case, and it's important it's understood, you are advisors rather than decision makers. You give advice to ministers. But is it your joint view that without these measures, that there is a serious risk, to put it no stronger than that the NHS intensive care capacity would be overrun?
I should say this slide is from the NHS. So this is the NHS view of what would happen based on the SPIRE modelling.
Do you agree with it?
Yes.
Right. And Professor,
I mean, given the caveats of sure. It's a model, but I mean, yes, this is what this
maybe
is
the problem
says, and it could be
as the chief scientific advisor to the government, to the Prime Minister, your advice would be based on this modelling that there is a serious prospect of the intensive care capacity of the NHS being overrun within the period to which this graph refers.
If nothing is done, yes.
If without these measures, which comes to the importance of the inquiries into these forecasts, because to accept that ministers decide and advisors advise, in practice, if the advice from advisors is that to the Prime Minister is that the capacity of the NHS is likely to be overrun within weeks, that is quite difficult advice to gainsay, is it not? And that's the reason why I think there's an interest in understanding the basis of the advice. It's not really optional advice in that sense, is it?
Well, I think that was the forecasting from the NHS. That's what they said, and
but it's also what you said.
It's what we say from the modelling, but it's what the NHS. I mean, as I said, we can't deal with NHS capacity. I don't have insight into the NHS capacity.
But your advice to the Prime Minister and the government, based on NHS data and the modelling data, was this is a serious prospect, is a serious risk for this.
Yes.
I understand.
And I think Chris, you'd be in the same.
Yes, serious risk, not inevitable. And the actions already being taken by people are already having an effect. But our view is, it's just a matter of time. Once the R is above 1, it'll keep on going up, and the question is only how long.
Thank you. Well, just on that, before I turn to my colleague Graham Stringham. So my question is, do these forecasts, these projections, include the impact of the tiered restrictions that began in most parts of the country on those parts that were affected on the 14th of October?
They won't yet be feeding through, in my view, fully into the numbers. But what those would do is push them out in time. They wouldn't change. So the question is not a question of whether. The question might be a question of when. Now, the only part of the country where at the moment I think there is realistic evidence that the numbers have flattened, where the R is approaching 1, is probably, in terms of regions, the northeast. There may be some smaller areas elsewhere. But it is still, as far as we can tell, still going up, albeit at a much, much lower rate. And this is the view of the local directors of public health, as well as the central view, as well as the NHS view. So this is a quite widely held view. I think that what you're indicating, and rightly, is that putting exact dates on these things is almost impossible. There's what government does. There's also how people themselves respond to the fact that they see a problem locally. And so neither Patrick nor I nor anyone who's advising government would say this is definitely going to happen on this date. And I think people who give that degree of certainty have not understood how modelling of this sort with scenario uncertainty properly works. But the inevitability that if your R remains above 1, even if it's by quite a small amount, once you've actually got to a high level of bed usage, you've got very little headroom. So quite a small R can take you from I'm just about coping to I'm not coping. And that is we're looking forward in a bad way to the fact that the most difficult time for respiratory viruses, we all know, for all respiratory viruses, is over the winter months. We haven't fully even got into them. So the chances things are likely somehow to improve without action between now and the next few months are quite low. So I think that if you're giving advice to ministers, that has to be the advice you give. Now, ministers then have to make decisions not just on that advice. They have to use multiple other things. These have big social and economic impacts that ministers have to take into account is right. The elected ministers make those decisions. This is one strand of advice, and I think quite strongly that it is really important that these deeply difficult societal measures fundamentally are decided by ministers.
I understand that, and the point that I've made is that if the NHS can cope and things can be accommodated, then there are decisions that ministers can make about the impact on the economy. It is, I think, much more difficult to make choices and decisions if the bottom line is that people are going to be dying in the car parks of hospitals. But there's a specific issue I want to explore on this. I quite understand that specific dates are not possible to ascribe to models. It's the shape of it that counts. But given the presentation that was made and the analysis that was made that justifies action that the House of Parliament are considering this week, that information, that presentation analysis was given on the 31st of October. Surely it would be reasonable for that analysis to include an assessment of the prospective impact of measures that were decided many weeks before and indeed became operational on the 9th of October. Why is the experience of, even the prospective experience, of measures taken and implemented on the 9th of October not factored into the analysis that you shared with the country on the 31st of October?
It is, to the extent that the medium-term projections that were approved on Thursday. So they are the latest estimate from SPI-M on the medium-term projections, taking into account all of the data that they have up until that moment.
So they include an assessment of the impact of the tiered restrictions in different parts of the country? As
far as those tiered restrictions have had their impact at that point. So they were looking on that date at the data that they could have at that moment. But those data, of course, are also backward-looking. So they're not going to be able to necessarily project everything that happens as a result of changes that are not yet known.
Well, we know what those restrictions were,
yes.
And those restrictions were chosen, presumably on the basis that they were going to have an impact on the prevalence and the hospitalisation, and ultimately the deaths and the capacity usage of hospitals. So you must have an assessment of what they were likely, or let's say they hoped to achieve, and there's at least 2 weeks and perhaps a bit more of data on what they were achieving. So were they factored into the projections of the impact on the NHS that was presented on the 31st of October?
They are factored in the forward projection is the best estimate by the modelling groups of what would happen going forward,
including the impact of those tiered restrictions.
Well, if you look at the performance of the 6-week projections over the last month, the actual data has tracked very, very closely to the projections, suggesting that they are pretty good in terms of being able to look forward, taking into account what would happen, but they can't be perfect because no model ever is.
So what has been the impact, the modelled impact of these tiered restrictions that were introduced early in October? How much have they reduced the number of modelled deaths by, or how much, to refer to Professor Whitty's point, how far back have they pushed the prospective peak?
Shall I first go at that, Patrick? I mean, I think it is difficult to be absolutely confident about how far their effect has gone. I am confident that the Tier 2 has had an effect, and that the Tier 3 has had a bigger effect. I'm confident of that, and it's the colleagues, the community in the North and Midlands in particular, where most of these are now, obviously London for Tier 2, and some parts of the East of England as well, have responded remarkably to this, and because of that, I am confident that the rates are substantially lower than they would have been had those activities not happened. But the early indications we have at present are that this is not achieved getting the R below 1. It has brought it much closer to 1, but it is still doubling. over a longer period of time. It's not possible to put an absolutely accurate fix on that, unfortunately, but we're doubling, as I've said already. We've now got hospitals already, like in Liverpool, which are above their previous peak. And it doesn't take much increase from that till you run into quite serious trouble. So the ability to actually hang on and say, well, let's wait a couple of weeks, let's just see what happens. The problem is, as you know, that the people who are in hospital now were infected several weeks ago. So there's quite a long lead time between taking an action and having an effect on reducing the number of people going into hospital, going into intensive care, and sadly in some cases dying. And therefore, if you wait too long, you've baked in a very large backlog of things where the rates are still going up. And we do not have, in my view, clear evidence at this point that R is below 1 in anywhere that we actually have significantly high rates, and that's a reality which I think my NHS colleagues in the north of England would say they recognise.
I understand that lagged effect, obviously, on admissions and ultimately deaths, but it is the case in Liverpool, for example, which you cited, that the peak level of positive tests was around the time of the imposition of Tier 3, around the 9th of October, at about 3,500 positive tests a day, and that's the 7-day rolling average. The most recent 7-day rolling average, and it's come down consistently since that peak, is about 1,900, so falling towards about half that rate. So does that indicate, in your view, that the Tier 3 restrictions are working, and has that been fully captured in the modelling that is being put forward to justify the new national restrictions?
So, looking at the data, particularly in the north of England, and I tend to look backward at data rather than, I find more than quite short forward projections for exactly the reasons you're giving, Chair. I'm very cautious of. I'm much more interested in how the data is playing out in real time and immediate past, and therefore the immediate future. And what we are seeing is that the rates, particularly in younger people, have fallen, and that's some combination of probably some slight reduction in uptake, but also some levelling off and possibly reduction in positivity rates. So I think there's a real effect and an artificial effect, if you see what I mean. But we are not seeing that reliably in the older age bands as it's moved up through the age bands. And that's important because actually the rates falling in people in their 20s will actually have remarkably little impact on the NHS. A few people in their 20s get into serious trouble. More obviously may have long-term morbidity problems, not necessarily getting into hospital, but the group of syndromes which are currently called long COVID. But the rates are still steadily tracking up in all the data that I have seen in the older age groups, who are the ones who are likely to translate into hospitalizations, ICU cases, and deaths. So I think it would be quite, it would require a really extraordinary degree of confidence that the overall data were translating through to say these isn't still going up in the age groups who are most vulnerable to having severe outcomes and ending up in hospital, and in some cases having very bad outcomes. So it's that age differential which I don't think is necessarily captured in the headline figures, and I think that people who aren't spending their entire time looking at hundreds of pages of data see the headline and they think, well, it's going down, and that's reassuring, not necessarily going down overall, but the rate of increase is going down. But there is this quite marked age differential, whereas it's the younger adults where the reduction is most marked.
So you think that the fall in positive tests in places like Liverpool, quite marked fall over the last few weeks, is not reflected in the prevalence amongst older people?
Correct. This is a differential effect amongst different ages. And now my hope is that it is now levelling off in the older ages as well, and I think there's some evidence that may be beginning to happen. But it's certainly not to the point where you could reliably say, well, just, I know the models show this, but actually I think it may be going lower than that, because actually that isn't what we are seeing in these older age groups. I would be delighted, obviously, if the answer was they were going down faster than the data currently are showing. and there's always a bit of a data lag, and if that was the case, that would be very good news. But I think it would be very imprudent to work on that basis.
So the implication of that is that these local lockdowns, the tiered measures, are not working for older people.
I think the implication is that with all the tiering, I think they have slowed things down from where they would have been otherwise. I think that would be my judgment as to where we are, and more in Tier 2 than in Tier 1, and more in Tier 3 than in Tier 2. And that's due to remarkable work of individuals taking really quite difficult social decisions for quite prolonged periods in many of the towns of the north. And I think we should not forget how long some of them have been in these measures. But there is no evidence, in my view, at this point, that in the older age groups, the R is now reliably falling below 1. It may be in some places approaching 1, and therefore the doubling time is going out in time. That is not the same as the doubling time turning to a halving time, which is what you want to see.
Thank you. It's precisely for that reason, Professor Whitty, for people that have suffered restrictions for a long period of time, they, I think, would want to be reassured that their experience has been reflected in the model and that we're not justifying a national lockdown without reference to the experience that they have on behalf of the country gone through. Would you publish the model, the NHS capacity usage model that lays behind these figures? Because it is such a pivotal one for the measures that are taken.
Well, the data that I was talking about were not NHS data. Those were the JVC test and trace data. They're not my data, but I don't see any reason why anyone would not want to publish data of this.
Would you write to the committee in the next few days with the details?
Well, as I say, it's not my data to release, but from my point of view, it should be openly available. And almost all of the key headlines are openly available in almost all areas through PHE and other routes.
You're the Chief Medical Officer. I think you're a man of influence. I'm sure.
All I'm just doing is I'm trying to avoid promising something which I can't guarantee to deliver. I'm pretty confident I can, and I want to, because I wish people to see. I'm very strongly in favour of people seeing the data. I'm very strongly in favour of it.
Grimsby.
Just following up on the point you were making about infections increasing in elderly, more vulnerable people, which is the key criterion? Is it the R figure, or is it the rate of infection in elderly people?
Well, the rate of infection in elderly people, the number of people infected, tells you what is going to happen in terms of in a small proportion, but an important, because the total numbers are very large, a significant number of people having severe effects. That's the strongest predictor of what will happen in the NHS is what has happened in people over the age of 60, for the sake of argument. Actually, of course, it's much greater in those in their 70s and much greater again in those in their 80s. It's not a cut-off, it's a kind of log linear curve. But the R is giving you a sense of is this doubling if R is above 1, or is this halving if R is below 1? And at this point in time, all around England, R is either above 1 or tending towards 1, but not falling at this point overall. And that's the figure that comes out of SPI-M. Patrick's in a better position to talk about that. But the R is a kind of summary figure. But actually, what you can see is it's either rising or it's falling, and that's the key question. The R, in a sense, is a reflection of that.
I understand that the R is a composite figure, and what I'm really asking is if, just to give a hypothetical example, if R is at 0.8 or 0.75, but there are a lot of infections amongst elderly people and hospitalisations, which is the key factor in your recommendation?
So in the immediate term, the number of people currently infected is the key thing. But the R will tell you that actually you've got this number of infections now, but if it was 0.8, I would be delighted if it was 0.8, and that would tell me that if I look forward 2 weeks, 3 weeks, 4 weeks, the numbers of people who are newly incident cases would be going down. We'd be back to a situation where the numbers were halving rather than doubling. But currently, as I say, they are doubling in most places.
So Patrick, Professor Whitty said before, for anybody familiar with modelling, it was clear what was going on. The vast majority of people in this country are not familiar with modelling. I think it's fair to say that. Was it sensible or fair to put forward the graph with 4,000